And I can take this off.
Yes.
Okay.
Hi, everyone. Welcome. Week 2 of intern year. So I'd like to introduce Dr. Emily Gilbert. She is one of our pulmonary and critical care attendings, and she's going to be lecturing on acid base today.
Okay, all set. All right, so I don't see a ton of familiar faces, so maybe a lot of you guys are interns. But if you do work with me in the ICU, you'll soon quickly learn that I love acid base. I love ABGs and trying to figure out all these like complicated problems that come along with it. So we'll go through the basics. We'll talk about how I work through acid base problems. And then if we have time at the end, I want to work through some problems. And that's how you kind of get better at this, is working through problems. Okay, so we have to start with some definitions. So acidemia is when the blood has an increase in hydrogen ions and the arterial pH is less than 7.36. Acidosis is the process that leads to that decrease in pH. So acidemia versus acidosis. Alkalemia is a decrease in hydrogen ions and an increase in that pH to more than 7.44. And the alkalosis is the process that leads to that increase in pH. So before you kind of try to attack an acid-base problem, you have to know what's normal, right? So a normal pH is 7.4, give or take 0.04. A normal bicarb is 24, and a normal PCO2 is 40. So if you just start by knowing the normals, then you can figure out when there's something wrong with it. So if you see a low pH, right? So less than 7.36, this is going to be an acidosis. Next thing you want to do is look at the bicarb. If your bicarb is low, then you know it's a metabolic process, and the way that the body compensates for that is it'll breathe off CO2. It'll hyperventilate to drive down the CO2 to try to bring that pH closer to normal. Now, when I say compensate, the body will try to compensate, but it will never normalize that pH back to 7.4. If you see a normal pH in the setting of some sort of acid-base abnormality, you know that there's more than one process going on. If you see a low pH and the bicarb is not low, then you look at the PCO2. And if you notice with respiratory acid-base abnormalities, the pH change and the PCO2 change are in opposite directions, right? What the body does to try to compensate for a respiratory process is it holds on to bicarb or it dumps bicarb. So for a respiratory acidosis, it'll hold on to bicarb to try to drive that pH closer to normal. If you have an increase in pH more than 7.44, that's an alkalosis. Again, looking at the bicarb, if the bicarb is also up, you know that's a metabolic process, and the body will hypoventilate to try to compensate for the metabolic alkalosis. And if your PCO2 is down, causing your pH to go up, that's a respiratory process, and the body will dump bicarb to compensate. So looking at the arrows, you can look at patterns, right? So if all of your arrows are going in the same direction, that's a metabolic process. If your PCO2 and bicarb are changing in opposite directions, then your pH, that's a respiratory process. And if your bicarb and PCO2 are changing in different directions, then you know that's a mixed acid-base disorder. Okay. So this is a simplified version of the form that I gave to Magda to hand out to you guys. This is how I work through acid-base problems, right? So I first start out, is it an acidosis or an alkalosis? Is it a metabolic or a respiratory? And then I just kind of go down each column depending on what it is. So we will work through this whole thing. And then, like I said, we'll go through some problems at the end. So first, we're going to start with a metabolic acidosis. With a metabolic acidosis, right? So this is going to be a low pH and a low bicarb. First thing you want to do is check the anion gap. Next, you're going to look for respiratory compensation by using the Winters formula. Then you're going to do your delta-delta to look for a coexisting non-gap acidosis or metabolic alkalosis. And then finally, if you have a gap acidosis and you don't know why, then you check your osmolar gap. So the anion gap. The concentration of anions in the blood equals the concentrations of cations, right? There are unmeasured and measured anions and unmeasured and measured cations. The measured anions are chloride and bicarb. The measured cations are sodium and potassium. Potassium is so small, doesn't matter. Take it out of the equation, rearrange the equation, and you get sodium minus chloride minus bicarb equals the difference between your unmeasured anions and your unmeasured cations. Now, Unmeasured anions are more than the unmeasured cations. So a normal anion gap is 12. Keep that in your mind. With your normal pH of 7.4, your bicarb of 24, your PCO2 of 40, a normal gap is 12. But you have to correct your anion gap. Now, this is a little bit controversial, but the majority of your anion gap is made up by albumin, the negative charges on albumin. So if you have low albumin, your gap will be smaller. The classic equation is for every gram per deciliter below 4, which is your normal albumin, the gap will decrease by 2.5. So if you have an albumin of 2, right, that's less albumin, your anion gap will be smaller. So that person's normal gap will be 7. So you have to adjust the gap for the albumin. Now, where did this equation come from? About 3 months ago, I was in the unit, and one of the lovely pulmonary fellows questioned correcting the anion gap for the albumin. And I don't mind. I love when people question what I'm saying, because that makes me kind of go back to the literature and be like, is this really a thing still? So I went back to look to see where this equation came from. It came from this paper. This is 1998, so a long time ago, where they took about 250 ABGs. And what they did was they measured the anion gap, the sodium minus the chloride minus the bicarb. And then they calculated the concentration of gap anions. That's what this GA is right here. And they looked and they could see that when at an albumin of 4, here they do grams per liter, but at an albumin of 4, there's no difference between the calculated anion gap and the measurement of the gap anions. As that serum albumin gets lower, your calculated gap gets smaller, but the gap anions stay the same, right? So you see that there's a bigger difference. So if you calculate the slope of this line, that's where they came up with the 2.5 for every gram below 4 your albumin is. Now, I don't know if you guys ever look at this website. I'm sure you do, because everybody does. This is the PulmCrit or MCrit. So Josh Farkas, who writes a lot of things on here, does not like correcting the anion gap for albumin. He says it's not helpful. But I'll tell you why I like to do it. Because it improves the sensitivity, right? You don't want to miss a gap acidosis. So take this, for example. Let's say that this is a patient, he's 85, he comes in with abdominal pain and diarrhea. You calculate your anion gap, sodium minus chloride minus bicarb, and you get a gap of 13. That's pretty close to normal, right? Normal gap is 12. So your attending says, and it's probably just a non-gap acidosis from diarrhea. Let's give him some fluids, Imodium, send him on his way. But you, being the astute residents, you notice his albumin is 2. So you're like, wait a second, if his albumin is 2 and albumin makes up the bulk of the anion gap, then that person's normal gap is 7. So that's a high gap for him. So you adjust your gap for the albumin, you readjust it, you add 2.5 for every point below 4 your albumin is, and you get a gap of 18. Again, in your mind, 12 is always normal. This is an elevated gap. And so now you start to go down the pathway. What's the reason for this gap acidosis? You check a lactate and it's 5.5. So instead of just being like diarrhea and gastroenteritis, this potentially could be mesenteric ischemia. You don't want to miss a lactic acidosis. You don't want to miss DKA. These have high mortality. So that's why I like adjusting the gap for the albumin. So I don't miss this, right? It improves my sensitivity, doesn't really improve my specificity very much, but again, you don't want to miss the lactic acidosis. So that's why I adjust the gap for albumin. So after you've checked your gap and adjusted for albumin, next you're going to do is check for respiratory compensation using the Winters formula. So when there's a metabolic acid-base abnormality, the lungs almost immediately respond, right? You have immediate ventilatory response. So in order to determine if that's an appropriate response or not, you have to calculate your expected PCO2 based on your bicarb. So 1.5 times your serum bicarb plus 8 plus or minus 2. If you have appropriate compensation, your measured PCO2 will equal your expected, the PCO2 off your gas. If the patient is overcompensating, they're hyperventilating, they're driving their CO2 down lower than expected, that's a respiratory alkalosis, right? So when you drive your CO2 down lower, your pH goes up, respiratory alkalosis. If they are unable to compensate for that low bicarb and they're hypoventilating, then that's a coexisting respiratory acidosis. Their CO2 is too high, so their pH is low. Okay, delta. This is my favorite, but a lot of people get confused about this. So this is how I think about it. What you're using the delta for is to assess for a non-gap metabolic acidosis or metabolic alkalosis. This is how I start. For every change in my gap, there will be a corresponding change in the bicarb. So if my gap goes up by 10, my bicarb will go down by 10, right? A normal gap is 12. So if my gap is 22, it's gone up by 10, my bicarb will drop by 10. It goes from 24 to 14. Always start with that. If your bicarb has changed by more, there's something else pulling that bicarb down further, like a non-gap acidosis. If your bicarb is higher than expected, then something's pulling that bicarb back up, like a metabolic alkalosis. That's how I do it. You can do the delta-delta, you can do this Dr. Dilling method. That's the way I think of it. It's always a one-to-one change. And then I look at my bicarb. And if the bicarb changes less, there's something pulling it back up. If the bicarb changes more, there's something pulling it back down. So another way you can do it is do your delta-delta. This is the difference between your delta anion gap and your delta bicarb, A minus B. If it's 0, if there's no difference, then it's a simple gap acidosis. If it's negative, I always think negative acidosis because your pH is lower, negative. So if it's a negative, your delta-delta is negative, you have a coexisting non-gap acidosis. And if it's positive, it's a coexisting metabolic alkalosis. This is Dr. Dilling's method that he taught me when I was a fellow. You take your measured bicarb, you add your delta gap, and if it equals 24, that's a simple gap. If it's less than 24, less means acidosis. More than 24, positive means alkalosis. We'll work through a couple of problems. Pick the way that works best for you. Again, I don't use either of these, I just think about it in my mind, but do whatever works best for you. So let's go through a couple examples. So here's a BMP. We get a calculated gap of 22. Normal gap is 12, so our delta gap is 10. Our bicarb's down to 14. Normal bicarb is 24. Our delta bicarb is 10. So one-to-one change, you're done. It's a simple gap acidosis, but you can do your delta-delta, delta anion gap minus delta bicarb is 0, or you can take that delta gap, not the actual anion gap, the delta gap, and add it to your serum bicarb, 24, whichever way you do it, it's a simple anion gap acidosis. Here's another one, 135 minus 110 minus 10, calculated gap of 15. So our delta gap is only 3. But our delta bicarb is 14, right? So if this was just a simple gap, it should be a delta gap of 3 and a delta bicarb of 3, but something's pulling that bicarb down further. You do your delta-delta, it's a negative number, or you can take that 3, add it to the 10, it's less than 24. Whichever way you do it, there's a non-gap acidosis on top of your anion gap acidosis. Does that make sense? So causes of a high anion gap, it's usually due to increased unmeasured anions. Rarely, if there's a severe metabolic alkalosis, it can decrease your cations, but it's usually due to increased unmeasured anions like keto acids or lactate. 2 different mnemonics. Mud piles is the one we've all learned, right? I think they're still teaching that in medical school. It's kind of old fashioned. So the newer one is Goldmark. The reason is because peraldehyde doesn't really occur anymore. And INH and iron are just causes of a type B lactic acidosis. So everything else is in the new mnemonic. So the reason that they want to add this is because there's a couple other things that you need to keep in mind when thinking about an anion gap acidosis. So glycols. This is ethylene glycol, right? So this is the classic ethylene glycol poisoning, which can lead to those calcium oxalate crystals in the urine. Propylene glycol. This is when you have high dose ativandraps. It's made with propylene glycol, so this can cause an anion gap acidosis. Oxoproline is a newer type of, or newly recognized type of anion gap acidosis in patients chronically taking Tylenol, not to be confused with Tylenol overdose, which causes an anion gap acidosis due to hepatic necrosis and lactic acidosis. L-lactic acidosis is the one we see all the time. D-lactic acidosis is something that you need to think about in patients with short gut syndrome. They have D-lactate producing bacteria, which can lead to D-lactic acidosis. Our lab cannot differentiate between L-lactic acidosis and D-lactic acidosis. So if you see somebody with an elevated lactate and you can't figure out why, and they've had a bowel resection or something like that, then think D-lactic acidosis. Methanol poisoning breaks down into formic acid, which is one of the unmeasured anions. Aspirin toxicity. So this is the classic gap acidosis, respiratory alkalosis. This is so classic. It's on every single board exam. Renal failure. CKD, early stages does not lead to a gap acidosis. That leads to a non-gap acidosis. But as you are approaching end-stage renal disease, you start to hold on to some unmeasured anions like urate and hippurate, and that causes a gap to occur. And then ketoacidosis can be alcohol, starvation, or diabetic ketoacidosis. Some people put a second R in there, so MARRK for rhabdo would be another thing. So type A lactic acidosis, again, this is what we always see, right? This is the hypoperfusion, higher lactate equals higher mortality, and it's not just sepsis, right? Anything that causes organ hypoperfusion can lead to a lactate, right? So cardiogenic shock, hypovolemic shock, septic shock, all of those things can lead to a higher lactate, L-lactate type A. Type B is L-lactic acidosis that is not due to tissue hypoperfusion. So it could be due to any of these mechanisms. Either you have increased lactate production, seizures, asthma, so increased respiratory muscle use. Some of the highest lactates I've ever seen are in the setting of leukemia, lymphoma. So always something to think about when you have a high lactate, but there's no evidence of shock, no evidence of tissue hypoperfusion. Anything that increases production of pyruvate, which is the breakdown of pyruvate leads to lactate. So epinephrine, dobutamine, some of the HIV meds can have increased production of pyruvate. Decreased lactate clearance, like we see with hepatic dysfunction, and then some unknown mechanisms, the classic one being metformin. So going back to our toxic alcohol ingestions, we mentioned how ethylene glycol, which is antifreeze, and methanol can cause an anion gap acidosis. Ethylene glycol breaks down into oxalic acid, that's the unmeasured anion, and it can lead to those calcium oxalate crystals in the urine and renal failure. Methanol, which is moonshine or windshield washer fluid, breaks down into formic acid, that's your unmeasured anion, and it can lead to vision loss. We had one of these in the unit a couple of years ago. And then isopropyl alcohol breaks down to acetone and can cause CNS depression. Ethylene glycol and methanol can increase the anion gap, and all three can increase the osmolar gap. So if you have somebody with an elevated anion gap and their lactate's normal and they're not in ketoacidosis and you can't figure out what's going on, there might be a suggestion of some sort of toxicity, check an osmolar gap. This is how you do it. Here's the equation, 2 times sodium plus glucose over 18 plus BUN over 2.8. Don't forget the alcohol if your serum alcohol is elevated. A normal osmolar gap is 10 to 15, and higher than 25 would be an osmolar gap suggesting some sort of toxic ingestion. Okay, so that's gap acidosis. Questions on that? Yes?
The osmolar gap, will that be affected by if they've got enough fluids or blood products recently?
It shouldn't.
It shouldn't.
I
Okay.
don't think so. Not that I've heard of. Okay, moving on to not, yes.
I've seen different people handle this different ways, and I have no idea what the right answer is, but our measured gap that we, gets autopilot, the normal range is like whatever, to 14 and 15 or something.
Yeah.
And I've seen people that handle it very different ways, and I don't know if there is a right answer.
I think they always put a range, right? So for like the delta, they'll say like, oh, 0 to plus or minus 6. And I'm like, well, that's an enormous range, right? Like, how are we ever going to figure out anything if we have that big of range? So I always think 12, always 12. And the gap that is calculated on the BMP, that obviously is not taking into account the albumin. That's just straight calculations. So I always just say 12, give or take. Okay, non-gap acidosis. So a normal gap is because you are losing bicarb, but in response to the loss of bicarb, the body holds on to chloride. So you can see here, the bicarb goes down, the chloride goes up, your gap stays normal. So an example would be something like GI losses of bicarb, like diarrhea, and the kidney retains sodium chloride. So your gap doesn't change. This is the old mnemonic, right? Used cars. I don't really like this one. I like rages. I think that's easier to remember. So renal. Would be RTAs or CKD, like we talked about. CKD causes a non-gap, end-stage renal disease causes the gap. Acetazolamide or hyperal is the A. G is GI losses, right? This is going to be your most common cause of a non-gap acidosis, either diarrhea or fistulas. Endocrine, I put hypoaldo under there because that can cause a type 4 RTA. And then saline, that's the other one, right? Normal saline can cause a hyperchloremic non-gap metabolic acidosis. So I like rages to remember the causes of a non-gap acidosis. You can check for a respiratory compensation. The Winters formula works for both types of metabolic acidosis. And then if you don't know why they have a non-gap acidosis, one of the things that you can do to determine whether it's a renal loss or GI loss of bicarb is check a urine anion gap. That's urine sodium plus urine potassium minus urine chloride. A normal gap is 0 to slightly positive, and it's really negative. That's going to indicate GI losses, negative. That's how you remember that. Okay, so before we move on to alkalosis, let's talk about what happens in the body when the pH starts to drop. So patients who are acidemic are very sick, right? Their lactate's super high or their DKA. And so when the body is failing, when the organs are failing like that, the body's going to try to increase delivery of oxygen to the tissue. So it's going to increase the cardiac output, cause decrease in SVR, coronary vasodilation. It's going to shift that curve to the right, so that it increases offloading of oxygen to the tissues. So it has a lot of protective effects, having a low pH in your blood. But obviously a lot of bad things happen too, right? In order to compensate, you've got to increase your minute ventilation. A lot of times these patients are so sick, they can't do this. So they need to be intubated to compensate, help them compensate for their acidosis. They can get hyperkalemic, they can become altered. And then there's this anecdotal decreased response to vasopressors. Have you guys heard this before? That when you're acidotic, yeah. So I've never really believed that this is a real thing. So last year when I was preparing for this talk, I looked up, tried to dig through the literature, and I found this paper. This is from 1958. And yeah, if you drive down the pH of dogs to 6.76, then yeah, they don't really respond as much to vasopressors as you would expect. However, when your pH is 6.76, it's probably because your lactate's like 22, right? And you're in multi-organ failure. So are you not responding to vasopressors because you're in multi-organ failure and you're about to die? Or is it really just the pH alone that's driving that poor response? So it's really hard to separate. There's never been any human studies showing a decreased response to vasopressors. Everything's been in animals. So I don't really believe this. I think it's just the fact that they're super sick. If your pH is 6.7, you're probably not going to survive. So does that mean that we should give sodium bicarb to people with a lactate of 22? This is one of my favorite papers. It was written by our own Dr. Forsyth when he was a fellow in 2000, talking about why you should not give sodium bicarb to patients with a lactic acidosis, and why. So when you give bicarb to somebody with a high level of hydrogen ions in the blood, you have a bolus in CO2 in your blood. And that's because hydrogen ions combine with bicarb to produce water and CO2. So if you measure CO2 in the blood after a bolus of sodium bicarb, it goes real high. Then the CO2 diffuses into the cell and causes an intracellular acidosis. You can have a decrease in your ionized calcium, which can affect your cardiac function. And 1 amp of bicarb will increase your sodium by 1 milliequivalent and will increase your extracellular plasma volume by about 250 cc's. So lots of downsides. So because of all these downsides, it's not recommended in lactic acidosis if your pH is more than 7.1 and your bicarb's more than 6. But are there some patients who might benefit from bicarb? So this was the bicarb ICU study. This was published a few years ago in Lancet, where they randomized patients to receive sodium bicarb or placebo. And these patients were sick. Their pH was less than 7.2. Their PCO2 was less than 45, so it was not a respiratory acidosis. Their bicarb was less than 20, and they needed to be in organ failure, defined on SOFA more than 4, or their lactate was over 2. So these are really sick patients. And what they found was that in the overall population, all comers, no difference in mortality, placebo versus bicarb. But if you looked at those who had AKI at the time of randomization, there was an improvement in mortality in the group that got bicarb. And even more impressive, if you looked at the secondary endpoint of who needed dialysis, you can see the patients who needed dialysis, the percentage of patients who needed dialysis way lower in the bicarb group. So there are some patients who would benefit from bicarb. So let's talk about who. I stole this from MCRIT. So let's talk about who shouldn't get it. The lactic acidosis and the ketoacidosis probably would not benefit from bicarb. Fix the underlying reason, right? Fix the reason their bicarb is 22. Fix the reason they're in DKA. Fix their acidosis that way. Don't just give them bicarb and potentially give them more fluid and more sodium and cause this bolus of CO2, because it's not going to help them. Who will it help? Well, look at the non-GAP acidosis group. So those are usually the diarrhea, right? So when you're having diarrhea, if you have a cirrhotic and you're loading him up with lactulose and he's having all this stool and his bicarb's dropping because he's losing a ton of bicarb, then give that bicarb back. That makes sense. You poop out bicarb, give the bicarb back. I get that. But what about this middle group? These are the group that maybe benefited in that bicarb ICU group. This is the AKI. This is like the hyperkalemia. That's how we treat hyperkalemia, is we give them bicarb, right? For severe hyperkalemia. And if you're in renal failure or hyperkalemic, and you're thinking about dialysis, but it's only to fix the acidosis or the hyperkalemia, right? So many nephrologists have told me, well, dialysis is just a big bicarb trip. So the only thing that's different about dialysis, you can pull off fluid. So if you're thinking about for AKI or hyperkalemia, you can try a bicarb trip. And maybe that would allow you to avoid dialysis. So none for lactic acidosis or ketoacidosis, maybe for the AKI and hyperkalemia, and yes for the non-GAP acidosis. Okay, moving on. Metabolic alkalosis. So causes of metabolic alkalosis are usually going to be a volume contraction, right? Diuretics, vomiting occasionally. Those are the primary causes. There is a respiratory compensation formula. I never, ever, ever use this. In fact, every time I do this talk, I'm like, oh yeah, I forgot about that. So there is an equation out there that you can use. It's this: delta PCO2 equals 2/3 the change in your bicarb, if you were curious. But the CO2 will not increase much more than 55, right? The body's never going to like just entirely stop breathing to compensate for metabolic alkalosis. It kind of peaks at about 55 and then it'll stop compensating. If you try to figure out why the patient has a contraction alkalosis, you could measure the urine chloride. There's chloride responsive and chloride unresponsive metabolic alkalosis. The chloride responsive is what you're most likely going to see. That's due to the diuretics or dehydration or vomiting. The chloride unresponsive is only in the setting of pure hypokalemia or a hyperaldo state. Now, like we talked about with acidemia, where so many effects of acidemia are cardioprotective, the effects of alkalemia are worse than those of acidemia, right? We don't really care if there's you see a pH of 6.7 and we all freak out, but if we see a pH of 7.6, 7.7, nobody seems to be that worried. But the effects are actually worse than acidemia. So you'll have decreased coronary blood flow, arrhythmias, hypoventilation. That curve shifts to the other side. It shifts to the left. So now the hemoglobin's holding on to oxygen tighter. There's decreased offloading of oxygen to the tissues and decreased cerebral blood flow. So acidemia, alkalemia, both very dangerous. Okay, moving on to the respiratory acid-base problem. So respiratory acidosis is right high CO2, low pH. So that could be due to underlying lung disease, whether it's increased dead space due to asthma or COPD. It could just be the patient's not breathing enough, right? So they're hypoventilating because of depression of their respiratory center. Or it could just be that they can't breathe enough. They can't breathe strong enough to breathe off that CO2 due to some sort of neuromuscular disease. A respiratory alkalosis, so sepsis, hypoxia, anxiety, some sort of central process, these patients are hyperventilating. Like we talked about, salicylate overdose, that leads to a GAP acidosis and a respiratory alkalosis. Progesterone is a respiratory stimulant. So you see increased progesterone in pregnancy and cirrhotics. So pregnant patients and cirrhotic patients will chronically hyperventilate. They will have a CO2 in the 30s and a pH of 7.47, something like that. So when you see a respiratory acid-base abnormality, you want to figure out if it's acute or chronic. The kidneys, I love the kidneys, but they're a little bit slow, right? So it takes about 3 to 5 days for them to start to really get into gear to compensate for some sort of respiratory abnormality. So in the acute setting, the change in your pH will be greater than in the chronic setting, right? In the chronic setting, the kidneys have had time to kind of pick up speed and either hold on to or dump bicarb. So in the acute setting, your pH change will be larger because the kidneys haven't had time to compensate. So what you do is you look at your change in your PCO2 and you look at your change in your pH to determine whether it's acute or chronic. So if it's an acute respiratory acidosis, and let's say your PCO2 has gone up by 10, so now it's 50, your pH will go down by 0.08. So 7.32, 50 would be an acute respiratory acidosis. Whereas if it's a chronic process, the kidneys have had time to kick in. It's been 3 to 5 days, more than 3 to 5 days. If your PCO2 is 50, your pH change will only be down by 0.03 once. So 7.37. And for every bump up in your PCO2, your pH will change by that amount. So again, we'll go through some problems looking at this. So how much does the bicarb change with these to compensate for these respiratory acid-base problems? 1425, if you put this in alphabetical order: respiratory acidosis, acute chronic; respiratory alkalosis, acute chronic. The way I remember it is 1425. For a lot of chronic respiratory acid-base problems, the kidneys kind of get to a cap where they can't dump it, they can't hold on to any more bicarb, or they can't dump any more bicarb for these chronic respiratory acid-base problems. So after about a PCO2 of like 70 for the chronic respiratory acidosis, I think the kidneys kind of max out at how much bicarb they can hold on to. And the reason I talk about this is because of a problem that we'll talk about at the end. So this is the table. A lot of people don't really remember the bicarb changes, but if you just focus on the pH changes, 0.08 for acute and 0.03 for chronic. And again, if you're doing your math and your pH is lower than expected or higher than expected, or your bicarb change is higher or lower than expected, you know there's another acid-base problem on top of everything. Okay, so this is the end of the review. We have about 20 minutes to go through some problems. So, and these, I think I took all of these from real cases that we had here in the unit. So, and we'll work through these. You can use your sheet and we'll work through these just the way I went through in the review. Okay, so this is a 49-year-old female. She has a history of spina bifida, colitis. She's got an ileostomy and an ileoconduit who's admitted with a seizure. Her pH is 7.35, her PCO2 is 30, and her PO2 is 100. You can see her BMP there, bicarb down to 16, albumin of 3. So, first question, acidosis or alkalosis? What do you guys think? Good. So pH is less than 7.36. This is an acidosis. Metabolic or respiratory? Metabolic, right? You look at the bicarb, that's low. You look at the PCO2, that's low. The pH is low. All the arrows are in the same direction. This is a metabolic process. GAP or non-GAP? 142 minus 118 minus 16. So I get 8. Even if you adjust for your albumin, you get to 10.5, right? Because your albumin's 3. So this is a non-GAP. What do we do next? Check our Winters formula. Is there appropriate respiratory compensation, right? So it's serum bicarb, 16 times 1.5. So 8 plus 16 is 24, plus 8, 32, plus or minus 2. We look at our PCO2, it's right there in the range. So this is appropriate respiratory compensation. And then you're done, right? So you have a non-GAP metabolic acidosis with appropriate respiratory compensation, likely due to her end ileostomy. Good? Okay. Next problem. This is a little bit tricky. 7.38, 1675 is her ABG, or his ABG. He's 51, diagnosed with HIV, admitted with hyponatremia with a sodium of 121, diarrhea, concern for sepsis. That is a nasty looking BMP, right? So 121, serum bicarb down to 12, albumin of 2. So what do you think? Acidosis or alkalosis? Acidosis, kind of, right? I mean, it's like really, it's near normal. So you know that because your pH is so normal with a bicarb of 12, there's got to be multiple things going on here, right? So if we say this is an acidosis, would you say this is a respiratory or a metabolic acidosis? Metabolic, right? So bicarb's down, PCO2 is down. GAP or non-GAP? 121 minus 98 minus 12. I'll do the math for you. It's 11, but right? So you got to add 5 to the gap, right? Because our albumin is 2. So I get a gap of 16. So this is a gap acidosis. Again, you don't want to miss a gap acidosis. Don't forget to adjust for your albumin. Is there appropriate respiratory compensation? What's your Winters formula? So is he overcompensating or is he undercompensating, right? So 12 times 1.5, so 12 plus 6 is 18, plus 8 is 26, plus or minus 2. So he's overcompensating, right? He's overbreathing. So he's hyperventilating. He's breathing his CO2 down further than he needs to. He's supposed to be around 26, but he's breathing it down to 16. So he's got a respiratory alkalosis on top of his metabolic acidosis, which is probably what's driving that pH back up, right? Okay, so he's got a gap acidosis with the coexisting respiratory alkalosis. He's hyperventilating. Now we do our delta. So what's our delta gap? We have a gap of 16. What's our delta gap? 4. What's our delta bicarb? 12, right? 24 minus 12. So we've got a delta gap of 4 and a delta bicarb of 12. So do whichever way you want. What do you think is going on here? A non-gap acidosis, right? There is something pulling that bicarb down further. Or you can do your delta A minus delta B, you get a negative number. It's a non-gap acidosis. So he has a triple acid base disorder. He's got a gap acidosis, probably due to, I'm trying to remember. Oh, yeah, he had a lactate of 6.6. So he's a gap acidosis due to his lactate of 6.6. He's got a respiratory alkalosis because of his sepsis, and he's got a non-gap metabolic acidosis due to his diarrhea. Good, right? Wasn't that easy? See, there you go. Okay, problem number 3. This is something we see a lot in our ICU. So, or we were consulted by the CCU. History of CAD, status post-CABG, CHF on diuretics, intubated. Respiratory therapy calls you and says the patient is apneic during spontaneous breathing trials. So, acidosis or alkalosis? Alkalosis, pH is greater than 7.44. Respiratory or metabolic? So we look at our bicarb. So our pH is up, bicarb is up, metabolic, right? All our arrows are going in the same direction. So this is a metabolic process. Okay, this is that weird formula, so I'm not even going to expect you to remember it. Change in your PCO2 is 2/3 your change in your bicarb. So our change in bicarb, so 39 from 24 is 15. So 2/3 of 15 is 10. So expected PCO2 is going to be a change, expected change in PCO2 is 10. So that's an appropriate respiratory compensation because hypoventilating to compensate for the metabolic alkalosis, right? If you really wanted to hammer the point home, you could measure the urine chloride. This is a chloride responsive metabolic alkalosis due to diuresis, right? So the body, so the reason the patient is not breathing during spontaneous breathing trials, the patient is hypoventilating to compensate for the metabolic alkalosis due to overdiuresis. So what do? You just try to get the bicarb down a little bit. 24-year-old male found down at a party, drinking excessively, doing drugs, then passed out. So 6.92, PCO2 of 100, bicarb of 30. Acidosis or alkalosis? Metabolic or respiratory? This is a respiratory, right? So we look at our bicarb, it's going in a different direction than our pH. Our PCO2 is going up, so it's up, up, and down. That's a respiratory process. Acute or chronic? So our PCO2 has changed by 60, right? A normal PCO2 is 40. So our PCO2 has gone up by 10, 6 times. So if it's an acute process, how much should our pH change by? 0.08 times 6, which is 0.48. 7.4 minus 0.48 is 6.92. So if it was chronic, it would be 7.22. So this is an acute respiratory acidosis. Check for renal compensation. This is the formula that you guys probably don't have to memorize, but for every 10 increase in your PCO2, your bicarb will go up by 1 for an acute process. And again, it's changed by 6. So 6 times 1 is 6. 6 plus 24 is 30. So he has appropriate renal compensation. So this is just a drug overdose, right? He's hypoventilating because of drug overdose. This is a good one. A BUN of greater than 300. That's got to be real. Okay, so this is a 71-year-old with a history of heart failure, reduced ejection fraction of 15%. 5 days of lethargy, altered mental status, hypothermic on arrival. So pH of 7.32, PCO2 of 18, bicarb of 7. What do you think? Acidosis or alkalosis? Good. Metabolic or respiratory? Right? Down, down, down. All the arrows in the same direction. Gap or non-gap? So 147 minus 122. So gap of 25, big gap. I don't even have an albumin. Appropriate respiratory compensation. So what's that? 7 times 1.5, 10.5 plus 18, 18.5 plus or minus 2. It's good, right? Appropriate respiratory compensation. This guy's doing a good job. Delta, delta. All right, let's look at our delta gap. What's our delta gap? 13. Delta gap 13. What's our delta bicarb? 17. So what do you think? This is something's pulling that bicarb down further than just the gap alone, right? There's a coexisting non-gap metabolic acidosis. So there's an anion gap metabolic acidosis with appropriate respiratory compensation and a coexisting non-gap metabolic acidosis. This must have been a real case. I wouldn't have made up these numbers, and I cannot remember for the life of me what this guy had, and I didn't put any notes down. So I can't explain why he has an anion gap metabolic acidosis, probably because of his renal failure and the non-gap metabolic acidosis. So, but there must have been a reason. Okay, this is, I don't know if Esther is on here. She's not here today, but this is a case that we had together in the winter. It was a COVID patient, 67-year-old man with hypertension, diabetes, admitted for COVID pneumonia back in November, right after Thanksgiving. He developed ARDS, he was intubated, he was proned and started on a Bumex drip. These are his labs in January. So this is probably hospital day number 40. pH is 7.34, PCO2 of greater than 107. That's where our lab stops in terms of calculating or measuring a CO2, PO2 of 96. Bicarb of 70, chloride of 66, and BUN of 75. When your chloride and your bicarb and your BUN are all the same number, that is a very, very bad sign. So this is a great case though. So what do you think? Acidosis or alkalosis? Acidosis. Metabolic or respiratory? So this is right, because you look at your bicarb and that's up and your pH is down. So your arrows are going in different directions and certainly your CO2 is up. So this is a respiratory acidosis, but if you do the math, right, to try to figure out if this is acute or chronic, if it's an acute respiratory acidosis, I mean, I'm assuming maybe he's about 110 for his PCO2. I have no idea. He could be 150, but our lab stops calculating after 107. So I'm just pretending he's 110 and saying that the change in the PCO2 is changed by 7 times. So if it's an acute change, our pH would be 6.84. Even if it's chronic, our pH should be much lower than 7.34. So you know that there's another process going on here. So maybe a chronic respiratory acidosis. I mean, this is going on for days and days. So we know this is chronic. So we check for renal compensation. Again, for every 10 increase in our PCO2, our bicarb should go up 4 for a chronic process. But our bicarb is increased by 46 instead of the 28. So there must be a coexisting metabolic alkalosis. So this, we're saying, is a chronic respiratory acidosis due to the tremendous amount of dead space he had from his COVID pneumonia and ARDS, and a metabolic alkalosis with hypochloremia because we were being so aggressive in diuresing him because his compliance was so poor on the ventilator. We just had nothing else we could do. So we were trying to diurese him as much as we could. So this was a great case. Just a couple more. This is another great case. So 35-year-old with bipolar who came in with tinnitus, vertigo, nausea, vomiting, diarrhea. pH of 7.53, PCO2 of 12, bicarb of 10. So acidosis or alkalosis? Metabolic or respiratory? Respiratory, right? Our arrows are going in different directions, right? So this is a respiratory alkalosis, acute or chronic. So look, our PCO2 has decreased by about 30, right? So if it's an acute change, 3 times 0.08 would be 0.24. So it should be about 7.64. But if it's chronic, 0.03 times 3 is 0.09. It should be 7.49. So it's kind of in between acute or chronic. Again, because this patient is like coming into the ER with these changes, we're assuming it's acute and maybe something else is pulling that pH down. And I know the story, so that is what happened. So this is, we think, an acute respiratory alkalosis. Is there appropriate renal compensation? No, you can just look at that bicarb 10. The body will never dump that much bicarb to compensate for a respiratory problem. So the change in the bicarb is much more than you expect for just compensation alone for a respiratory alkalosis. So there must be a coexisting metabolic acidosis. So now we go down that pathway. We switch to the other side of the paper. We go down our metabolic acidosis. Is there a gap or a non-gap? 135 minus 110. There's a gap. So she's got a gap acidosis. We go over, again, we're still on this side now. We're going back to the delta. Our delta gap is 15. Our delta bicarb is 14. Oh, I said 13 there. Oh, sorry. Yeah. Delta gap is 13. Delta bicarb is 14. So I would say that that's a normal delta. So there's no coexisting metabolic process. So this is an acute respiratory alkalosis with a gap metabolic acidosis. What is this? This is like this is aspirin toxicity. Shows that she was an aspirin overdose. We saw this a couple of years ago. So really cool. As a side note, you don't want to intubate these patients, right? Because if you intubate them, you take away that ability to compensate for this. So I remember when our toxicologist was here, she told us to never intubate an aspirin toxicity because we will never be able to do what they can do, right? Our ventilator will never be able to do what they can do. So try not to intubate these patients. Okay, this is the last one. This is a board style question, right? Where it gives you an acid-base problem. You got to figure out the acid-base problem, and then you got to figure out the diagnosis that goes with that acid-base problem, right? So I always include this on this talk. So those of you who have seen this before have seen this question before. But 7.63, PCO2 of 30, and a bicarb of 31. So is this an acidosis or an alkalosis? Metabolic or respiratory? You look at your bicarb and your bicarb's up, but your PCO2 is down. So I think it's metabolic and respiratory. So I think this is a respiratory alkalosis and a metabolic alkalosis on top. So we've got two alkaloses going on. And so now you have to think, okay, of these diagnoses, which of them cause both a metabolic alkalosis and a respiratory alkalosis? So COPD, what would you expect here? Respiratory alkalosis or respiratory acidosis? Acidosis, right? They have increased dead space. They hold onto CO2. Their CO2 goes up. Their pH goes down. So A and D are out. Pregnancy and liver disease. Pregnancy, liver disease, what do those cause? Respiratory alkalosis, right? So pregnancy, increased progesterone. Liver disease, increased progesterone. Those respiratory stimulants. So they hyperventilate. CO2 goes down. pH goes up. So B and C. Okay, so of hyperemesis and renal failure, which of those cause a metabolic alkalosis? Hyperemesis, right? You're vomiting, you're losing acid. Renal failure causes a non-GAP acidosis. So, B. That's it. Questions? Really? Okay, great. What did I do? Oh, well. Okay, great.